Many children we see in the emergency department will do well. Sometimes, though, a dangerous diagnosis can elude us. This could be because the presentation was atypical, or because the disease was hiding in someone we wouldn't expect. Identifying myocardial infarction in children is a lot like finding a needle in a haystack. Today, we'll use a special MI metal detector to sort out the sharp, jabbing truth and leave the rest behind. Let's start with how children present with MI. Cardiac symptoms in children are atypical. Rarely will they present like in adult males with crushing substernal chest pain and radiation of the pain, diaphoresis, nausea, shortness of breath. Children are more likely to have unexplained shortness of breath, or just nausea, or just low energy. Infants or younger children may simply be irritable or show poor feeding. So that should be all easy to sort out, right? Seriously, though, I don't say this to scare you. I just want us to keep our minds open to the possibility of cardiac ischemia when you see vague symptoms that are difficult to explain otherwise. This might be an easier way to think about it. Typical cardiac symptoms, the kind in textbooks or in the Framingham study, crushing chest pain, diaphoresis, a sense of impending doom, etc., all of those are testosterone. What's the typical way we men deal with something that hurts? We get angry at it. Premenopausal women who have lower levels of testosterone will present atypically. This is the woman in her 40s or 50s who just doesn't feel right. She feels drained of her energy. She's nauseated or short of breath. She's at risk for someone's downplaying her presentation or ascribing her vague symptoms to, it's all stress. But all of that is her prodrome to her MI. So, who else has lower testosterone levels? The elderly, both men and women. They're notorious for their atypical presentations of cardiac chest pain. And who else has relatively low testosterone? Children. Atypical is typical. Okay, so how do we sort out all of this atypical hay and find that gleaming needle that can turn up to poke us? We need a mnemonic. That's right, something that will come to mind when we need it right away. Here is our mental metal detector. When you think about atypical vague symptoms that might be cardiac in a child, to find the possible etiology, you gotta cath it. Cath it. C. Congenital. A. Autoimmune. T. Trauma. H. Hematologic. I. Infectious. T. Toxins. C. Congenital. There are two main presentations of MI due to congenital lesions, the novel and the known. The novel presentation is at risk for underdiagnosis because we don't expect to make the diagnosis of congenital heart disease in the ED. The good news is that there are usually some red flags with a careful history and physical. The known presentation is a child with a history of congenital heart disease, and he's been addressed by either corrective or palliative surgery. This child is at risk for any of the expected complications, and of course, with that comes overdiagnosis and iatrogenia. Like anything, it's a balance. Our first rapid-fire vignette. The fussy, sweaty feeder. ALCAPA. Anomalous left coronary artery from the pulmonary artery, ALCAPA is an example of what can go wrong during fetal development. Any abnormality in the number, the origin, the course, or the morphology of the coronary arteries can present as a neonate with sweating during feeds. This is a type of Steele syndrome. ALCAPA, or other anomalous connections, can present in an infant with a new diagnosis of congestive heart failure. Or this may be an older child with failure to thrive or even poor exercise tolerance. The stable child with chest pain. The myocardial bridge. Normal coronary arteries run along the epicardial surface of the heart with projections into the myocardium. If part of the artery's course runs within the myocardium, meaning the artery weaves in and out of the cardiac muscle, then there is a myocardial bridge of the coronary artery. So what? This means that with every systolic contraction, the artery is momentarily occluded. If all is well, it actually doesn't usually bother you. Many of us are walking around minding our own business, none the wiser that we may have a myocardial bridge. Although it may not cause symptoms, especially in the distal portions, the area it supplies potentially is at risk. With any minor trauma or overexertion, demand may outpace supply, resulting in ischemia. The diagnosis of myocardial bridge is made on coronary angiography. The unwell child post-cardiac surgery. Fontan problems. The child with single ventricle physiology may have a series of palliative procedures to convert his dominant ventricle to an engine for his circulatory system. The Norwood procedure is done at birth. It involves the creation of a neo-aorta with an atrial septectomy and a Blalock-Taussig shunt. This allows mixing of the right and left circulations and a passive venous return that powers the forward flow. The single ventricle now functions as the systemic ventricle. At 3 to 6 months of age, the next stage is done, the bidirectional Glenn procedure. Now the shunt is removed and the superior vena cava is connected to the pulmonary arteries. At 2 to 3 years of age, the toddler outgrows the venous return supplied by the Glenn, so he needs an upgrade, the Fontan procedure. Here is where your inferior vena cava blood flow is shunted directly into the pulmonary arteries for a better venous return and forward flow. Now, don't worry if that's hard to visualize. The main point here is that there are a lot of plumbing hacks and rerouting that's done to make the best of a single ventricle that pumps mixed venous and arterial blood into the circulation, and it's powered only by its preload that involves only passive venous return. The point I'm making here is that these children depend on their preload to run blood passively into the pulmonary circuit. They need to be euvolemic, and they are exquisitely sensitive to hypovolemia, even from a simple acute gastroenteritis. Chronically, they'll also benefit from afterload reduction. That poor single ventricle is overworked. We want to avoid the slow development of pulmonary hypertension. These children are typically also on an anticoagulant, usually aspirin, and a diuretic, usually furosemide. Also, they may have an afterload reduction agent like enalapril. Anything can throw them off. Maybe there's a problem with volume status, even hypervolemia or hypovolemia. Maybe a problem with anticoagulation or changes in afterload. Any of these can cause myocardial strain or infarction. Take the child after Fontan seriously and involve a specialist early with any concerns. cathate, C. congenital, A. autoimmune. The body's inflammatory-mediated reaction to a real or perceived insult can cause short and long-term cardiac sequelae. In the child with an autoimmune disease, find out how well it's controlled at baseline and what complications the child has had in the past. But be ready to pick up on a new presentation like the red, hot, crispy, flaky child, acute Kawasaki disease. Kawasaki disease is an acute systemic vasculitis diagnosed by the presence of fever for 5 or more days, accompanied by 4 or more of these criteria: bilateral conjunctival injection, mucositis, cervical lymphadenopathy, polymorphous rash, and palmar or sole desquamation. The criteria may occur or disappear at any time during the illness. Infants are under double jeopardy with Kawasaki disease. They're more likely to have incomplete Kawasaki disease, so they may not fulfill all strict criteria initially. And if they do have Kawasaki disease, they're more likely to suffer from the dangerous consequences of aneurysm formation. This is chiefly the coronary arteries, but you can also see aneurysms in the brain and kidney. Have a low threshold for investigation. Treatment includes 2 grams per kilogram per day of IVIG and high-dose aspirin acutely, then low-dose aspirin for weeks to months later. Regular and long-term follow-up with a cardiologist is required. The aftermath, sequelae of Kawasaki disease. The family and child with a history of Kawasaki disease may have psychological trauma and continuous anxiety about the child's risk of MI. This is not unfounded. Approximately 5% of children who were promptly diagnosed and correctly treated, regardless of what we do, will go on to have cardiac sequelae. The good news is that children who have no detected cardiac sequelae by 8 weeks typically continue to be asymptomatic up to 20 years later. Smaller aneurysms tend to regress over time, especially those that were less than 6 millimeters. Thrombi may calcify, or the lumen may become stenotic due to myofibroblast proliferation. Children with any coronary artery dilatation from Kawasaki disease should be followed indefinitely. Giant aneurysms, so those greater than 8 millimeters, connote the highest risk for MI. Parents often are concerned about recurrence, and any subsequent fever can be distressing for them. Luckily, there is a low rate of recurrence for Kawasaki disease. Only 2% of children who had Kawasaki disease at one point will develop it again. Infants who have coronary aneurysms are at the highest risk for recurrence. The older child with vague chest complaints and hypercoagulability, systemic lupus erythematosus, and antiphospholipid syndrome. Up to 15% of cases of SLE begin in childhood. Adult criteria are used, with the caveat that the diagnosis of SLE in children can be challenging. Many children only manifest a few of the criteria initially before going on to develop further systemic involvement. The Systemic Lupus International Collaborating Clinics revised the criteria in 2012. The patient should have 4 or more of 17 clinical and/or immunologic criteria. The clinical criteria are acute cutaneous eruption, a malar rash, chronic cutaneous eruption, a discoid rash, oral eruptions, alopecia, synovitis, serositis, renal, neurologic, or hemolytic anemia, leukopenia, or thrombocytopenia. The immunologic criteria are ANA positive, anti-double-stranded DNA, anti-Smith, antiphospholipid, low complement, and/or direct Coombs. At least one criterion should be clinical, and at least one should be immunologic. Children with antiphospholipid syndrome may or may not have SLE. These patients are at risk for venous and arterial thrombi formation. Antiphospholipid syndrome may also cause structural damage, like valvular thickening and valvular nodes. This is the Liebman-Sachs endocarditis. Mitral and aortic valves are at the highest risk. Now, this is just too much for us to keep in our minds all at once. We can always look this up. Although most children with chest pain and lupus will not have MI, those with comorbidities should be investigated carefully. Congenital autoimmune trauma. Direct, blunt trauma to the chest can cause myocardial stunning, or a dysrhythmia, or even an asymptomatic rise in troponin, even in normal, healthy hearts. However, some children are at risk for disproportionate harm because of an unknown risk factor. The motor vehicle collision, blunt myocardial injury. Direct trauma from a steering wheel or airbag or seatbelt, especially in fast acceleration-deceleration mechanisms of injury, may cause compression of the heart between the sternum and the thoracic spine. Start with an EKG. A negative ECG is highly consistent with no significant blunt myocardial injury. Any patient with a new abnormality on ECG, so a dysrhythmia, some heart block, or signs of ischemia, should be admitted for continuous ECG monitoring. Elevation in troponin is common, but it's not predictive. A solitary elevated troponin without ECG abnormality is of unclear significance. The new EAST guidelines call for both a normal ECG and a normal troponin to stratify someone as low risk and a possible home candidate. My advice, get a troponin if there's an abnormal ECG or more than a fleeting suspicion of blunt cardiac injury, and or if the child is going to be admitted for monitoring. Children who are hemodynamically labile should be resuscitated, and you should get a STAT transesophageal echocardiogram. The high velocity object, coronary artery dissection or thrombus. Direct trauma, like with a motor vehicle collision or a baseball or a soccer ball hitting the chest, it can cause damage to the left anterior descending artery or the left circumflex artery. These are at the highest risk because they're the closest to the chest wall. Blunt trauma of these arteries can cause thrombosis or dissection. There may be a focal pattern of ischemia on the ECG. If you're at all concerned, just get the echocardiogram. It may show valvular damage related to the injury, as well as the possibility of effusion or diminished ejection fraction. Since there's often a need to investigate the coronary anatomy, percutaneous coronary intervention is also recommended in these cases. The minor trauma with disproportionate complaints, myocardial bridge. Remember the myocardial bridge we talked about earlier? It comes into play here. Even minor trauma in a child with the myocardial bridge may cause acute thrombus or a slow stenosis from resulting edema. Remember, for the most part, a myocardial bridge is asymptomatic until someone has a disproportionate reaction to an illness or injury. Approximately 25% of the population may have a myocardial bridge based on autopsy studies. Take the child seriously who has disproportionate symptoms to what should be a minor injury. Okay, cathit, congenital, autoimmune, trauma, hematologic. Coagulopathic and thrombophilic states may predispose children to focal cardiac ischemia. The best documented comorbidity is in sickle cell disease, although other prothrombotic conditions may also put the child at risk. The child with sickle cell disease and chest pain, when it's not acute chest syndrome. Sickle cell disease can affect any organ system, basically any organ that is perfused. The heart traditionally has been considered a lower risk target organ for direct sickling and ischemia. The major cardiac comorbidity in sickle cell disease is from strain or high output failure. Often in sickle cell disease, there are multiple serial episodes of increased myocardial demand, which causes left ventricular hypertrophy and potentially congestive heart failure. These are all subacute presentations. However, there is mounting evidence that acute myocardial ischemia in sickle cell disease may be underappreciated or attributed to other causes of chest pain. Other cardiac sequelae from sickle cell disease include pulmonary hypertension, left ventricular dysfunction, right ventricular dysfunction, and chronic iron overload. Evidence of myocardial ischemia or infarction in children with sickle cell disease has been demonstrated on single photon emission computed tomography, or SPECT scans. The puffy-faced child with chest pain. Nephrotic syndrome hypercoagulability. Children who suffer from nephrotic syndrome lose proteins that contribute to the coagulation cascade. To add to that, lipoprotein profiles are altered. There is a rise in the bad, very low density lipoproteins, the LDLs, contributing to accelerated atherosclerosis. Typically, nephrotic patients have normal levels of the good high-density lipoproteins, the HDLs, unless there's profuse proteinuria. Children with difficult-to-control nephrotic syndrome, typically those who are steroid-resistant, may form accelerated plaques that rupture, causing focal MI as early as school age. The previously well child now decompensated. Undiagnosed thrombophilia. Asymptomatic patent foramen ovale is the cause of some cases of cryptogenic vascular disease, like stroke or MI. However, the presence of a PFO alone doesn't connote higher risk, but when you pair it with an inherited or acquired thrombogenic condition, the venous thrombus may travel from the right-sided circulation to the left, causing distal ischemia. Many of these cases, unfortunately, are unknown until a complication arises. The chronically worried, now with a reason. Hypercholesterolemia. A family history of adult-onset hypercholesterolemia is not necessarily a risk factor for early complications in children, provided the child doesn't have the same acquired risk factors as adults, like obesity or a sedentary lifestyle or smoking. Parents may seek help in the ED for children with chest pain and no risk factors, and only adult parents who have poor cholesterol profiles. You may treat these children just like any other, but this may be a good opportunity to plant the seed of good diet and exercise in the child. The exception is the child with familial hypercholesterolemia, a genetic condition who is at risk for accelerated atherosclerosis and MI. Congenital, autoimmune, traumatic, hematologic, infectious. The main player here is myocarditis. But myocarditis is not just one entity. but it's a palette of varied presentations with varied etiologies. Mostly infectious, but also due to medications like chemotherapy agents, or it can be immunologic, like rheumatologic diseases or transplant rejection. Think also about toxins, arsenic or carbon monoxide, or heavy metals like iron or copper. Even physical stress can cause myocarditis from electrical injury, from heat illness, or radiation. In children, of course, the most common cause of myocarditis is infectious. So this may be a virus, protozoan, bacterium, fungus, or parasite. Of these, viral causes are the most common. Think of adenovirus, enterovirus, echovirus, rubella, or HHV6. The verbal child may complain of typical chest complaints or may come in with flu-like illness and tachycardia or ill appearance out of proportion to presumed viral illness. The most common presenting features in children with myocarditis are shortness of breath, vomiting, poor feeding, hepatomegaly, respiratory distress, or just fever. The infant in shock after a cold, myocarditis. Beware of the poor feeding, tachycardic, ill-appearing infant whose parents try to assure you that he has just a cold, doctor, because everyone in the family has a cold. That may very well be true, but any virus can be invasive with myocardial involvement. Infants are only able to increase their cardiac output by increasing their heart rate. They can't respond to increased demands through inotropy. Look for signs of acute heart failure, just not able to keep up with the tachycardia. Look for hepatomegaly, respiratory distress, and sacral edema. The school-age child with tachycardia out of proportion to complaint, myocarditis. The previously healthy child with a bad flu may simply be very symptomatic from his influenza-like illness, or he may be developing myocarditis. For the verbal child, ask about chest pain and think about tachycardia out of proportion to his presumed illness and that constant chest pain that doesn't go away, not just associated with cough. The pneumonia with a suspicious chest X-ray, myocarditis. Acute heart failure may mimic viral pneumonia. Look for disproportionate signs and symptoms. Cathit. Congenital, autoimmune, traumatic, hematologic, infectious, and toxic. Younger children may get into other people's medications. Maybe someone gives them a dangerous home remedy. Or maybe he takes some drugs recreationally. Or he has an environmental exposure like a heavy metal. Or he may suffer from a consequence of a comorbidity like iron or copper overload, or just an adverse event from generally safe medications. The hyperactive boy with a hyperactive precordium, methylphenidate. Attention deficit hyperactivity disorder, ADHD, is growing in rate of diagnosis and its use of medications. It's the only medical diagnosis based on self-reported criteria, and so many children are given stimulants regardless of actual neurologic disorder. Since we have a higher proportion of children exposed to these stimulants, we're going to see more and more adverse effects in the ED. Methylphenidate, used for ADHD, is related to amphetamine, and they're both dopaminergic drugs. Their mechanism of action, though, is different. Methylphenidate increases neuronal firing rate. Methamphetamine reduces the neuronal firing rate, and cardiovascular sequelae like MI and CHF are more common in methamphetamine use. Although methylphenidate is typically well tolerated, risks still include dysrhythmias like ventricular tachycardia. The child with seizure disorder and chest pain. Anti-Epileptics. Some anti-epileptic agents, like carbamazepine, promote a poor lipid profile, leading to atherosclerosis and possibly early MI. Case reports include school-age children on carbamazepine who have foamy cells in the coronary arteries, in their aorta, and their vasa vasorum on autopsy. It's unclear whether this is a strong association or a causation. The spice trader. Synthetic cannabinoids. Synthetic cannabinoids are notoriously difficult to regulate and to study, since the manufacturers label them as not for human consumption. Once reports surface of abuse of a certain compound, then the formula is immediately altered slightly, then repackaged, often in a colorful or mysterious way that's very attractive to teenagers. There are two main misperceptions with synthetic cannabinoids. First is that it's thought that synthetics are related to marijuana, so they should be safe, and the second one is marijuana itself is safe. Both of these misconceptions tend to steer unwitting teens to take these unknown entities. Some suffer MI as a result. Exposure to tetrahydrocannabinol, or THC, in high-potency marijuana has been linked to myocardial ischemia, to ventricular tachycardia, and ventricular fibrillation. Marijuana can increase the heart rate from 20 to 100%, depending on the amount ingested. K2, or Kush 2.0, or Spice, Zohai, Genie, K3, Bliss, Nice, Black Mamba, Fake Weed, all of those things. It's a mixture of plant leaves doused in synthetic chemicals, including cannabinoids and fertilizer. None of these are safe for human consumption. Synthetic cannabinoids have a higher affinity to cannabinoid receptors, conferring higher potency and so worse adverse effects. They are thought to be 100 to 800 times more potent than marijuana. Bath salts like Purple Wave, Zoom, Cloud9, all of those floaty feel-good names, these can be ingested, snorted, or injected. They typically include some form of cathinone, like mephedrone, similar to the substance found in the naturally occurring khat plant. Hallucinations, palpitations, tachycardia, MI, and dysrhythmias have all been reported from their use as a recreational drug. Chest pain with marijuana, with a synthetic cannabinoid, or a bath salt ingestion should be investigated and at least monitored. Riding that train. Cocaine is a well-known cause of acute MI in young people. In addition to the direct stimulant causes acutely, like hypertension and tachycardia and impaired judgment, so co-ingestions and other risky behavior, chronic cocaine also has long-term sequelae. Cocaine causes accelerated atherosclerosis. That, in conjunction with arterial vasospasm and platelet activation, is a recipe for acute MI in the young. Cranky. Methamphetamine is a highly addictive stimulant that is relatively inexpensive and widely available. Repeated use causes multiple psychiatric, personality, and neurologic changes. Risky behavior, violence, and motor vehicle accidents are all linked to this terrible drug. Like cocaine, methamphetamine may cause fatal dysrhythmias, acute MI from demand ischemia, and long-term sequelae like congestive heart failure. In summary, acute MI is a challenging presentation in children because it's easily missed, it's uncommon and atypical. It has a varied etiology. So respect the vague symptoms with a non-reassuring history and physical. Try to detect it. It's not too late. To CAF it. Congenital, autoimmune, traumatic, hematologic, infectious, and toxic. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.